Well, welcome. It's so nice to be back here after COVID, right? I missed you guys. I assume you found lunches and the waters and everything you need in the back. My name is Chuck Welch. I'm the Chief Strategy Officer here, one of the Vice Presidents at the health system. I've been at Hutchinson Regional about 4 years now. And unfortunately, we had been doing this, the first course, for about a year until we had to shut it down. So it's so nice to have you all back. One of the initiatives that Hutchinson Regional Medical Center has been involved in the last couple of years is, and part of my role actually, is to identify areas and service lines and needs within our community that aren't being met. For the longest time, we have needed a top quality pulmonologist in town. We just had Dr. Sork for a while, and now we have 3 fantastic pulmonologists. Radiation oncology, medical oncology. We've brought all of those service lines to Hutchinson, and they're doing fantastic. An area that we've needed for many, many years has been neurospine surgery. Spine surgery in general, but neurospine even more so. Dr. Frimpong, who has become a good friend of mine, comes to us out of Wichita. And I'll give you a little bit of background about him, but he is one of those additional service lines and one of those people that has come to serve our community in a very needed time. So Dr. Frimpong received his doctorate from the Medical School of Lake Erie College of Osteopathic Medicine in Pennsylvania. He completed his residency at Virginia Tech Carilion School of Medicine and completed his fellowship at Bassett Healthcare, Columbia University College of Physicians and Surgeons in New York. Dr. Frimpong's expertise includes removal of tumors of the brain and spine and navigation-guided spine fusion, along with placement of spinal stimulators and treatment of scoliosis, in addition to emergency work in cases of traumatic brain and spinal injury. And just in the short time he's been here, he has impacted or changed many, many people's lives for the better. So please give him a warm round of applause and welcome him. Thank you.
Oh, no. Thank you so much for the warm welcome. I'm going to make the presentation short so we can have more time for discussion, because that's really what's important. It's going to be a lot of information, but we'll try to get straight to the point to make it relevant to what you need here. So, Chuck, thanks so much for the introduction. It kind of went over a lot of brief of the stuff that I do here. So disclosures, I have no disclosures and no conflict of interest or anything like that. So this is surgical management of back and neck pain. Of course, there's a ton of topics I could have discussed about, but I think that this is the most common things everybody deals with. As you know, your whole spine is made out of 3 main sections. You got the cervical, thoracic, and lumbar. The thoracic region has the ribs, so most of those areas is protected most of the time. The area that majority of people have issues with, usually the neck and the lumbar spine, which is the most mobile portion of your spine. And as we all age, we end up with, degenerative diseases and pathologies of the cervical and thoracic spine. I will start off with a couple of objectives here. I want to discuss a little bit of the newer minimally invasive surgical interventions for spinal pathologies, and also want to talk a little bit about motion preservation in spine surgery. And we will, at the last minute, I spent a very few minutes to discuss about sagittal balance. The reason why I'm discussing these 3 topics is that, as you know, there are many ways to skin a cat or do a surgery, and as technology advances, the same surgery we've been doing in the past, it's just a less invasive way, less traumatic way of doing it. So I'll talk about some of that and shine some light on it. And we'll talk a little bit about motion preservation in the middle here. So minimally invasive surgery is essentially a way of performing surgery. So the traditional surgery that we all know of is you go, especially in the spine, we made a midline incision, you spread the muscles away, you find the pathology that you're dealing with, whether it's a stenosis, whether it's a herniated disc, whether anything that's pushing on a nerve that's what we need to remove. Then you go ahead and remove the pathology and you close it. Surgery works well, it's been done for many years. Typically patients do well. The problem is that sometimes after surgery, we as surgeons ends up creating more pain than the patient bargained for. So patients up with a lot of back pain from the incision itself and the muscle being stripped away. So as advances and things has progressed, we've come up with a different way of kind of addressing the same issue by causing less trauma to the patient. Hence the name minimally invasive. So we would make smaller incisions and achieve the same goal through a much smaller incisions. So what do we use minimally invasive surgery for? We use it for almost everything that you could do in an open spine surgery, with the exception of a few exceptions. So things such as routine spinal fusion, such as deformity cases, scoliosis, and decompression, routine decompression for herniated disc in the cervical and lumbar spine, and also infection, and also vertebral compression fracture repairs. There are some times that you cannot use minimally invasive surgery if somebody has a gross infection in the spine where you need to open everything up and see what you're doing, and also if a patient has had previous spine surgery and there's a lot of scar tissue and it's going to be much difficult to look or see those through a much smaller incision. In those situations, you want to make sure you open the spine the old-fashioned way and do it the traditional way so you could see, because you want to be able to see to be safe. If you can't see well, then you don't know where you are and the chance of potentially hurting a patient is much higher. So this is your typical minimally invasive surgery. You would see that the surgeon on the left-hand side wearing loops, and what you do is that you make a very small incision and you use dilators. So you put one dilation and you dilate the muscle slowly until you get the surgical corridor you want, and then on the right, they put a tube down there and it goes straight to the spines. You can see. So after the surgery, you just remove the tube and the muscle comes together. That way you're not making a huge incision, causing a lot of bleeding, and potentially creating a vacuum space where you could form seromas and potential infections and high blood loss. So the advantages of minimally invasive surgery compared to our open traditional surgery is that in the minimally invasive surgery, you have smaller incision, you have minimal muscle dissection, hence less pain after surgery, and you don't disrupt the muscle as much, thereby the patient does not end up requiring a lot of pain medication after surgery or stay in a longer time in the hospital than they should. And especially also in an older population where you don't want to use a lot of narcotics after surgery, or you don't want to be staying in, they may not be healthy, so you don't want to keep them in the hospital maybe as long. Doing the surgery minimally invasive helps people get out quicker, because most of the time the spine surgery, what keeps you in bed is the pain. You can't get up because it hurts. So if you could do the same surgery through a smaller incision where you could get up and move, overall you're able to get home faster and recover quickly and be able to heal much faster, and most importantly return to work or your hobbies and require less narcotics. So there's some disadvantage, it's not everything, there's some disadvantage of minimally invasive. So one of the disadvantages is that it takes a little longer than doing an open case, because you got to use more x-rays. Since you're not opening everything up, you kind of rely a lot on x-ray. Number two, there is the inability to cover all pathologies. Same pathologies as I listed before cannot be done through minimally invasive surgery because it's just better suited doing it open. And also there's an extended learning curve. So in some situations, most of the older surgeons that were not used to doing the newer techniques would tend to stay away from it, and they will only do it the open way, which works, but it may have a little bit of a higher more blood loss and potentially higher infection rate than the minimally invasive surgery. So there are different techniques. You could use robotics, you could use endoscope, You could use artificial intelligence and things like that to help you utilize minimally invasive surgery. I won't get too much into that details. We'll move forward. So the next topic I would talk about is motion preservation. I did brought in some models in the back, and we're going to pass them around. So traditionally, what I mean by motion preservation is that traditionally when we do spine surgery, we typically would decompress the spine, and after that we may decide whether to fuse it or just decompress it only. If you decide to fuse it, you would put screws in a plate or screws in a rod to essentially fuse a segment together, or multiple segments depending on what you're trying to cover. The idea of motion preservation is you don't want to fuse at level. You want a patient to maintain motion yet achieve the same goal. So after you've decompressed the spine, you either put an artificial disc, typically either in the cervical or the lumbar spine, so that the patient will still maintain motion and be still flexible in that area. That is important because that helps decrease the level of adjacent level disease. Okay, so this is an example of pictures. I don't know if people can see the pictures here, but on the far left hand side is a patient's neck, cervical spine, and that is what we call an artificial disc. So after I had removed the disc from that level, I will put in the artificial disc. Compared to the one on the right side following it, that would be your classic cervical fusion. Rather than putting the artificial disc, I had put a cage and a plate. The one on the right side has been done for many, many years. It works. The problem is that you are fusing that level, so you are eliminating motion from that level. It's pretty good to treat neck pain and things, but over time, sometimes you end up developing disease above the level that you fuse because you are making it rigid. You can't move it. While on the left side, it's still staying mobile. So the left side is more we're trying to mimic your own natural body mechanism so that you not end up developing an adjacent level or decrease the chance of an adjacent level disease. On the far right hand side, you would see that there's a lumbar artificial disc. So we've done a lumbar surgery, but we've put in an artificial disc. Compared to the very right hand side, you will see that after the surgery, we've put in screws and rod. So on the very right side will be your classic lumbar fusion case. Once again, it works for what we're trying to do it for if you're having a broken bone or something like that, definitely putting screws is the right thing to do. But if you have, let's say, a herniated disc and you just want to go in and address disc pathology and make room for the foramen, you could definitely achieve those objectives with an artificial disc and at the same time maintaining motion at that level and decreases the chance of adjacent level disease so that the level above doesn't deteriorate as fast as if you had put in screws and a rod, as on the right side. So this is a typical places you would do artificial disc, in the cervical and in the lumbar spine. In this country, we tend to do more of the cervical artificial disc. We used to do a lot of the lumbar artificial disc, but it's kind of falling out of favor because the outcomes compared to the artificial disc, we definitely got better patient-reported outcome measures with the cervical disc compared to the lumbar disc. So this is your classic how an artificial disc would work. It essentially trying to mimic all the different motions of your neck. So you have rotation, you have side bending, you have a back and forth motion. So that's what your disc do normally. That's how you're able to twist your neck up and down, rotate it. The disc does that. The artificial disc try to mimic that. So that's very nice because after surgery, you don't need to wear a brace because you almost have your mimicking your normal cervical disc. So these are some of the FDA-approved cervical disc, essentially in the U.S. So on the far left side, you would see that there's about 6 of them that's been approved by the FDA, and it's different generations. So each one comes and then gets improved. The newest one is M6 disc. I've done a few of those around since I've been in Kansas. And then on the right-hand side, you see the 2 that are FDA approved. It has the dates that were approved. The simplified disc was approved in 2020, while the secure seat disc lumbar was approved in 2012. The M6 disc was approved that's the newest one, which is what I'm talking about. It's approved was approved in 2019. And yeah, currently that's the newest technology out there for an artificial disc. So an M6 cervical disc is an example of a motion preservative designed to replace natural spinal disc. It mimics natural motion, including back and forth, side to side, up and down rotation, so that patient can retain their range of motion. And it's made with material specifically designed to selected for surgical implants, such as ultra-high molecular weight polyethylene and titanium coating. The M6 is among the most advanced motion preserving devices available today. So these are some of the FDA lumbar artificial discs out there. So comparing the surgeries, the difference between a cervical spine fusion and artificial disc and some of the risk involved. So this table essentially compares the two. So for a cervical spinal fusion or lumbar fusion, you essentially, with a fusion, you are fusing that level and you losing motion. You spend about 1 or 2 days in the hospital, and probably you wear a back brace for about 3 months. And about 6 months, the vertebrae will begin to fuse. Patients with neck patients who may benefit are those with pain localized to the neck for cervical fusion, and low back pain who may benefit are those with pain localized to low back or radiated into the leg. So those will be the patients that you do a fusion, whether cervical or lumbar. On the far right-hand side, we talk about the benefit of an artificial disc. You are preserving the motion, you are preserving the rotation, because that's what a lot of patients worry about when we discuss fusion, is am I going to lose motion? Am I going to be able to bend my neck? Am I going to be able to twist my neck after surgery? With the cervical artificial disc, the goal is to maintain that motion and not lose it because you're not fusing it. You spend also 1 to 2 days in the hospital. You are able to begin bending and twisting right away because you're not fused, so there's no limitations. With unlike the fusion on the left-hand side. Back to active in about 2 months. Neck patients who benefit are those with pain localized to the neck or pain radiated to the arms, and same as the low back, they have back pain radiated to the legs. The only problem with artificial discs, especially the cervical, is that if you have a lot of posterior cervical disease and you put in artificial disc, your arm symptoms may get better, but you may still have a lot of posterior cervical pain even with the artificial disc. So some patients, not all patients are candidate, and the key is trying to figure out which patient should you do cervical fusion on and which patient should you do a cervical artificial disc on. So risk related to disc replacement, is important to remember that any invasive procedure, any surgery at all, whether it's fusion, traditional way or artificial disc, there is risk involved. The implant could move out of position. It doesn't happen often, but it can happen just like with any hardware. It could break down. And the same with if you fuse, the plates and the screws could break. The implant may fail to relieve symptoms or preserve motion. Once again, it doesn't happen often, but it is a possibility. Okay, the next thing I will talk about, and this may be a little bit more in depth, but essentially the idea of sagittal imbalance and why it's important. So sagittal imbalance is how your body, your alignment to gravity and how you walk, how much your whole body is aligned with each other. A lot of times you may see, some patients, may have back pain and they'll be walking and they all lean forward. You could tell that their shoulders and their ear and everything is moved forward. So a patient like that, their center of gravity has moved forward. And when you are addressing their spine pathology, whether it's a fusion or herniated disc or anything like that, you also want to take that into consideration, because if you don't, then their pain, back pain, may not be relieved, because the pain may be coming from this sagittal imbalance itself, not just from that focal pathology that you are addressing. So patients that may have this, of course, aging population. As you get older, the center of gravity shifted, you have hip issues, knee issues, other things that may throw your center of gravity off. Patients that have had previous spine surgeries, whether lumbar or cervical spine, and sometimes too, you may have surgery, and that initial surgery may actually throw your sagittal balance off and give you an iatrogenic sagittal imbalance. So all that are things we need to pay attention to. So a typical example, the patient on the left side, hand side here, you could see that they had surgery before, but they're not standing straight. Look how much they move forward. Compared to this patient on the right side, you could see that they've had more hardware in them, but see the difference. They are able to stand, their ear is lined with their shoulders, and then it's lined up with their hips and everything. So patient on the right, even though it seems that they may have a lot more screws, they are more aligned, they're gonna have less pain than the patient in the left, even though the patient in the left also had surgery. The only problem is that the surgery stopped and they ended up with some proximal junctional kyphosis and some sagittal imbalance, hence a lot of pain. So until you address the whole issue and extend the fusion and address the focal pathology there, they are going to continue to have pain. So this is a scoliosis patient. You can see that this patient here, they have scoliosis, meaning their spine is crooked. But that's not the only issue. This patient also hip is bad. So when the patient comes in the office and they are seeing me as a spine surgeon, yes, I'm gonna try to talk to them about their back, because that's why they are seeing me. But we should not also ignore their knee, because their knee is also affecting their sagittal balance and also the way their hips are aligned, because that could be affecting, one hip is higher than the other, throwing off the center of gravity. All these other things too can cause somebody not to stand upright. Kyphosis, lumbar spinatus, back pain, muscle weakness, flat back syndrome. So we kind of went over this a little bit about what sagittal imbalance means, so I won't kind of bore it to death. But this is a patient that had surgery 15 ago and now coming out with some missatisfaction, or my back still hurt and I had surgery, it worked for a little while. The classic thing is, I had surgery, I had great relief for about 4 years, now the pain is back, what's going on? And then you do x-rays and everything looks okay, but they are still hurting. So you did an MRI, everything looks fine. The previous fusion looks like it's fine. That time we definitely needs to start looking at whether they are sagittally balanced or not. So this is lumbar fusion disease negative affect outcomes of hips. So one outcome, I put this on there to kind of relate how hip pathology correlates with back pathology. So if someone has a back issue and they have hip surgery, their outcome after the hip surgery is not as great compared to somebody who didn't have a back problem. So they are both intertwined. Same thing with back. If you have a back surgery and you're having a hip issue, ongoing hip issue, it also negatively impacts your outcome, how you're gonna feel, how you're gonna do after the back surgery. So if someone after the back surgery or hip surgery the outcome is not that great, we need to start thinking outside the box and start asking questions. Hey, is there something going on in the lumbar spine that we need to take a look at? Or is there something going on in the knees that we need to take a look at? Rather than saying, oh, the hips looks great, so I don't know where the pain is coming from because my hardware looks good, what I put in is fine, and that's that. We just need to start looking elsewhere to kind of come up with an explanation why the patient may not be doing so well. So why do we need to measure spinopelvic parameters, meaning certain parameters that we check to make sure that one is sagittally balanced? And the reason is that we've done multiple studies, outcome measures, and patient-reported, outcome measures and other studies that have shown us that some key spinopelvic parameters that we measure actually affect outcome. So when you're doing surgery, there are certain numbers you are measuring prior to surgery, and you try to achieve that during surgery, and you could measure those numbers after surgery to see if you achieve it to correlate with how the patient is doing. And these are some of the parameters that we try to measure. We try to measure how global alignment, how the patient is from the head to toe, and also what kind of curve they are having. Are they having some sort of kyphosis, scoliosis, and some of the pelvic parameters we pay attention to. So this kind of go over some of the morphology. There's something called pelvic incidence, which really doesn't change as you age. Pelvic tilt, some numbers there that I pay attention to, normal about 13, and you want to keep that less than 20 degrees in anything that you are doing. So we talk about pelvic tilt and pelvic incidence, sacral slope. So you want to pay attention to all these numbers as you're trying to fix somebody's alignment. So there's a lot of stuff that goes into it when somebody comes to you and they're not walking straight and you're trying to get them straight. A lot of measurements that you try to achieve, clear goals from certain numbers prior to surgery that you try to achieve before surgery. And based on how much correction you need, determine what type of surgical approach you try to use to achieve that goal. So this is classic, some of the normal numbers that you try to achieve. Sacral morphology and lumbar lordosis. So this is an equation we use, lordosis PI plus or minus 9 degrees. It's a lot of this. So this is effect of aging on sagittal balance. So typically life is a kyphosing event. What I mean is that, you stand up straight with your ear right on your shoulders and in your hips. This is how you look like when you are 18, 20, 23. And as life goes on, you start bending forward and bending forward and bending forward. And essentially, your center of gravity start going back, which is why low back pain is the second most common reason why somebody sees a physician, because we all age, and as we age, our center of gravity is thrown off, and it affects our global alignment, and it essentially causes pain. And gravity always wins, it's just like there's really no way around that. And these are some age-adjusted numbers, and this is my references. So try to make it brief, but really I want to open the floor so that you guys can ask specific questions as to things that are relevant to you and as it relates to spine, so I could try to answer it. Any questions at all? Yes, please go ahead. Let me get you a mic. Do we have a...
It works.
I'd like to know, do you do your surgeries only in Wichita, or do you also come to Hutchinson and do your surgeries?
Oh, I do. I try to do a lot of my surgeries here if I can. And the reason is that one of the main reasons why I came here is that there is a need that's not being met in this community. And my goal was to come here and do surgery here to keep the business in town, and also to make it efficient for the patients so they don't have to drive 2-3 hours. With that said, I've done quite a few cases here. I mean, we've done quite a lot here since the beginning of the year. I try to look at a case to make sure that the case is safe for us to do here. Most cases, about 80 or 90% of cases can safely be done here. But there are selected patients that if I see them here and I don't think that the case could be done here, I would refer for us to do it either at Wesley Medical Center, which I do surgery at, and also at Via Christi Hospital. But most spine cases, if I see them here, they are being done here. They're not being shipped to Wichita or anything, unless I think that's the right thing for the patient.
Who else has another question? Anybody?
Yeah.
What I've been off and on suffering with for a few years is something with my neck, and what it does is it runs down my right arm, and lately, like even sitting here, my arm just goes to sleep. I have to wake it up.
Yes.
So I was wondering what that has to do, because I know at one time one doctor years ago said that I might have to have some surgery done, but then it went away and I didn't have anything happen until just recently.
So the reality is that if on average, I do surgery on about 5% of patients that I see, okay? So if I see 100 patients, probably 5 or 6 or 7 of them may ultimately end up with surgery. So what we try to do is that when we see a patient like yourself, what we would do is that if there's no imaging, we would do an image to see exactly what's going on. Now, assuming that we've done MRI and seen something on your neck, then the next question is that what exactly do we need to do for you based on your age and what medical status that you have? Because not every patient is suited for a big surgery. So depending on that, once we pass that, then the next thing is that have you done physical therapy? Have you done injections in your neck? Because at the end of the day, we want to keep surgery as the last thing that we do. And then once you do that and it's still not working and you're still having a lot of pain, you're still having a lot of numbness, tingling, and weakness, then we talk about surgery, and that's when I'll offer you all the different options that I discussed and try to, and the older you are, the more we try to keep the surgery as simple as possible. Because most of the time, the problem is not so much the surgery, the problem is keeping you on the OR table too long. That's when problems happen. So when you're gonna have issues, whether it's heart attack, strokes, or anything like that, it's the longer you're on the table. So we try to see what the pathology is, what is the quickest and easiest way for us to do and address your issue and keep it simple and straightforward. Of course, the younger you are and the more you can tolerate being under anesthesia for a long time, of course, the more we offer you more options. But we really try to kind of get to the bottom of it. So there will be a clear plan of how we would do it. Mainly, we'll start off with an imaging to see what we are doing, and then we'll review your medical and figure out, are you a surgical candidate or you're not? And if you're a surgical candidate, we will offer you the options which I think will be the most appropriate for you based on your medical status and age and things like that.
Anybody else?
Many senior citizens have problems with dizziness. Does dizziness go along with the neck problems?
Yes, it could, or it may or may not. Sometimes dizziness by itself could be caused from many things. One of them, you could be having dizziness because you have an inner ear problem. You could be having dizziness because you have arthritis in your neck, and then there's a vessel here, your vertebral artery and your carotid. There's supposed to be a blood flowing through it to your brain. So you could be dizzy because sometimes you could have a bone spur pushing on the artery, and each time you turn your neck, you're not getting enough blood flow to your brain. That could cause dizziness. You could be dizzy because your heart isn't working too well, and you're not pumping enough blood. You could be dizzy because your heart has an arrhythmia. So as you age, the reason why many seniors, like you alluded to, have problems is because as you age, you start having those problems. You start having either a heart issue, an inner ear issue, an arthritis, and plaque. You start forming like plaque from all the food you've eaten over the years. Start building up in your arteries, decreasing the amount of blood flow, and all that. So yes, a neck pathology, assuming that you have a bone spur or something like that, pushing on some sort of an artery, it could cause you to be dizzy. But a spinal cord itself being pushed on typically doesn't cause dizziness, not the spinal cord itself. It will more cause balance issue. You may have premature balance because your spinal cord is being pushed, but you're not gonna be dizzy. You're more gonna have problem walking. So there's a big difference between that.
Thank you.
Yeah.
Who else? Anybody else?
Does physical therapy truly help stenosis, and does it last?
So that's a loaded question. And it depends on the degree of stenosis. So I've seen physical therapy work well for patients that have maybe mild to moderate stenosis. Once you get to a very high grade severe stenosis, those patients I think are better served with surgery, especially if they have a neurologic deficit. So in my practice, the way I do is that when I see a patient, I'll listen to their complaint, what they are coming to me with, and then I'll look at the images. If the images shows that they have a very high grade or severe stenosis, and I see a clear impingement on the neural elements, whether it's the spinal cord or the nerve, and they clearly have a neurologic deficit, whether it's numbness down the arms or weakness down the arms or balance issue, or they feel like they have to lean forward on a cot in a shopping, and a lot of times I could tell the patients that have stenosis in a shopping without even getting an imaging, because you see a lot of them all leaning over the cot, because that's what relieves the pressure. In those patients, I skip physical therapy and I go straight to surgery, because I think that's the right thing to do, because I don't think in those cases the physical therapy provide the long-term benefit that the patient is looking for. But on average, for patients with mild to moderate stenosis, yes, physical therapy does work. Because I've seen patients, they come to me, I send them to physical therapy, and I never see them back, which is good because they probably, pain is gone away.
Who else? Anybody else have a question? Gonna make me walk back here. Yeah, I get my Fitbits.
If a person wants to make an appointment with you, can that be done directly, or does a person need a referral from a primary?
It can be done directly. So we see patients as a self-referral. They just come and refer themselves to me, and I see them. I have my cards that we're going to be giving out, so people could call my office and schedule. It also depends on which insurance that you have. Some insurance requires you to have your primary care doc refer, but on average, if you have Medicare or something like that, you could just come straight to my office and we will see you and take care of you that way.